Hey, well, once again, hello nurses. Let's talk about medications used to treat abnormalities of the adrenal glands. Then we'll look at hypothalamic medications. So for the adrenal glands, there's three classes of medications: glucocorticoids, mineralocorticoids, and androgens. Some medications are going to overlap between the glucocorticoids and the mineralocorticoids. But for the most part, this division, I think, works pretty well. So some terminology first. Adrenal insufficiency refers to a shortage of adrenocortical hormones. That shortage produces symptoms. Those symptoms typically we associate with Addison's disease. An adrenal crisis refers to someone with an adrenal insufficiency who suffers from a period of extreme stress, severe infection, massive trauma, car accident, surgical procedure, so on and so forth. These people are treated with very large infusions of replacement steroid hormones or steroid hormone analogs coupled with life support procedures. So glucocorticoids, they increase glucose levels for energy. They also increase the levels of protein catabolism. They decrease the rate of protein formation. They increase gluconeogenesis. So they increase the formation of glucose from amino acids made by the degradation of protein. They increase the storage and synthesis of fat. So they increase lipogenesis. So they essentially create more energy for the body to use. Steroids, remember, pass through the membrane directly, bind to their receptor, which is in the cytosol. They enter the nucleus and activate the transcription of target genes. Those RNAs are brought to the cytosol where they undergo translation, and then the cell changes its behavior based on the new proteins that the cell has made. All steroids signal that way. So in the body, glucocorticoids will decrease inflammation. They suppress the immune response. They're very good for that. So they're used for inflammatory diseases like Crohn's disease, like ulcerative colitis, like rheumatoid arthritis, like psoriasis, like psoriatic arthritis, like systemic lupus erythematosus. Some glucocorticoids also have mineralocorticoid activity: cortisone, hydrocortisone, prednisone. Therefore, they will affect sodium, potassium, and water levels. Glucocorticoids can limit the activity of lymphocytes and inhibit the spread of leukocytes to injured tissue. So they're very good for inflamed tissues. They also decrease the expression of phospholipase A1. They prevent the liberation of arachidonic acid from membrane lipids, therefore preventing the synthesis of leukotrienes, thromboxane, and prostaglandins. So these are very wide-ranging anti-inflammatory activities. Common glucocorticoids include beclomethasone, betamethasone, budesonide, dexamethasone, hydrocortisone, methylprednisone, and prednisone. You can see if these drugs end in "sone," that's a pretty good indication they're steroids. Some of these drugs come in inhaled forms and are used for asthma. So budesonide, beclomethasone, fluticasone, those drugs are also used for asthma. Prednisone and methylprednisone are given orally for severe asthma. So these drugs are used for treatment of local inflammation. They're used for short-term treatment of inflammatory disorders. They're also used in cancer patients to decrease the wasting and pain that comes from cancer. And they're also used for adrenal insufficiency. Most of these are administered orally. They do come in foams, inhaled forms. There are IV forms. Mostly they're given orally. They tend to peak 1 to 2 hours, tend to be active for about a day, day and a half. Half hour again, this is a rough average, 3.5 hours. These will differ from drug to drug, but this is a pretty good ballpark. They're metabolized by the liver. The metabolites are excreted in the urine. Some other drugs that activate or inhibit cytochrome P450-3A4 can extend the function of some of these steroids. Some people can be allergic to them or to components in the preparations. When used during acute infection, glucocorticoids can increase the severity of these infections, so they must be used with caution. In diabetics, glucocorticoids elevate blood sugar and should be used with great caution, if at all. Other endocrine disorders necessitate the non-use of glucocorticoids, and they're also contraindicated during pregnancy. Again, inhibitors and inducers of cytochrome P450-3A4 will either increase or decrease glucocorticoid activity. That includes things like macrolide antibiotics, azole antifungals. These will increase the toxic effects of glucocorticoids. Drugs like salicylates, barbiturates, hydrantoines like phenytoin, or the antibiotic rifampin will decrease glucocorticoid activity because they induce cytochrome P450-3A4. So your job is to determine contraindications and cautions. So assess baseline weight, temperature, and affect. So ascertain grip strength, you have an eye examination, blood pressure and pulse, peripheral perfusion and vessel evaluation, respiration and adventitious pressure set breath sounds, make sure there's no fluid in the lungs, look for glucose tolerance and baseline blood glucose levels, renal function, serum electrolytes to determine basement status before beginning therapy, and also to detect potential adverse effects. So if you have altered output, cardiac output, rate related to fluid retention, look for that. So watch cardiac output. Look for excessive fluid volume related to water retention. So look for edema, pitting edema, signs of fluid retention, headache, distended jugular veins, and look for risk of infection related to immunosuppression. So administer the drug at the beginning of the day. This will mimic the normal peak diurnal concentration of glucocorticoids in the body. That will minimize suppression of the hypothalamus pituitary axis. Space doses throughout the day to achieve homeostasis. Taper the doses gradually to give the adrenal glands a chance to recover and produce the adrenal corticoids. Do not stop the drug abruptly. Protect patients from infections and invasive procedures that increase the risk of infection. And then educate patients, give them comfort as they deal with the adverse effects of the drugs. So monitor patient response to therapy. Look for relief of signs and symptoms of inflammation. Look for the return of adrenal function, normal adrenal function. Monitor adverse effects, thinning of the skin, fatigue, mood changes, things like that. Evaluate patient understanding of drug therapy by asking the patient to name the drug, name its indication, name the adverse effects to watch for, and then monitor patient compliance to drug therapy. For mineralocorticoid, the main drug is fludrocortisone. Fludrocortisone. Aldosterone is usually not given because of its short half-life. Fludrocortisone has a much longer half-life. That's the drug you normally give. These drugs help maintain proper electrolyte levels, maintain electrolyte and water homeostasis. Fludrocortisone will mimic the effects of aldosterone. So aldosterone increases sodium reabsorption in the renal tubules at the expense of potassium and hydrogen ions, leading to water and sodium retention. So this drug is used during cases of Addison's disease. And also it's used to treat salt-losing adrenogenital syndromes, and it's used off-label to treat hypotension. These drugs have a gradual onset. They peak at about 2 hours, but their duration is longish, 18 to 36 hours. Half-life's about 3.5 hours. Metabolized in the liver, excreted in the urine. Their pharmacokinetics is well understood. Contraindications. Patients have allergies against the drug. Don't use at all. Don't use in cases of severe hypertension, heart failure, or cardiac disease. Do not use on a lactating mother. Do not use or use with great caution in people with infections. And do not use in patients who must undergo high sodium intake. Adverse effects include possible hyperkalemia. Be careful, very, very careful in patients taking drugs that also increase potassium levels. Also prevent the patient from eating too much potassium-rich supplements or compounds. Look for skin rashes In cases of allergies, look for edema and signs of heart failure, and then look for headaches and weakness in cases of water intoxication. Salicylates, barbiturates, hydantoins, rifampin, and cholinesterases, all anticholinesterases, all of these will decrease the effectiveness of drugs like aldosterone analogs and things like that. So look for contraindications and cautions, assess blood pressure, pulse, breath sounds, weight and temperature, tissue turgor, reflexes and bilateral grip strength, serum electrolytes, and make sure that you establish a proper baseline to compare these parameters with those that you will detect after the drug is started. So look for excess fluid volume related to sodium retention. Look for imbalanced nutrition, more than bodily requirements related to metabolic changes. Look for impaired urinary elimination related to sodium. That is usually an effect of sodium retention. So use only in combination with glucocorticoids to maintain control of electrolyte balance. Increase the dose in times of stress to prevent adrenal insufficiency from going to adrenal crisis. Monitor for hyperkalemia, treat it accordingly. Discontinue if you see signs of overdose, excessive weight gain, edema, hypertension, and comfort the patients as they deal with side effects. So monitor the patient response to therapy, that they have proper maintenance of electrolytes and electrolyte balance. Monitor for adverse side effects, fluid retention, edema, hypokalemia, headache. Evaluate patient understanding of the therapy. Evaluate patient understanding of potential side effects. Monitor patient compliance with drug therapy. And now for a quiz to see how well you're listening. So glucocorticoids are agents that are released in response to high glucose levels. Glucocorticoids are hormones that help regulate water balance in the body. Glucocorticoids are hormones that help regulate electrolyte levels. Glucocorticoids are hormones that help promote the preservation of energy through increased glucose levels, protein breakdown, and fat formation. The answer is D. D. They're agents that stimulate an increase in glucose levels for energy. They increase the rate of protein breakdown, decrease the rate of protein synthesis from amino acids to preserve energy. They also stimulate lipogenesis for the formation of fat for energy storage. Question 2. Glucocorticoids reduce inflammation and suppress the immune system by activating more lymphocytes to reduce inflammation. B, inhibiting the localization of lymphocytes so the immune system can rest. C, by inhibiting phospholipase A2, preventing the production of arachidonic acid, the source of many pro-inflammatory mediators, D, all the above. The answer is C. C. Glucocorticoids do not do A or B, they do C. Question 3. A patient on aldosterone can eat all of the following meals except egg and vegetable breakfast crostini. B, bagel salad and cottage cheese. C, dried peas and beans. D, white bean and roasted red bell pepper hummus. The answer is B. Remember, the patient on fludrocortisone has to be on a low sodium diet. So all the following are low sodium except for B. Bagels and salad. Remember, salad dressing is high in sodium, and cottage cheese. High sodium intake should be avoided to prevent severe hypernatremia. Question 4. Patient started on a prednisone regimen. Because of a crisis in her ulcerative colitis, nursing care of this patient would require A, immunizations to prevent infections, B, increased calories to deal with metabolic changes, C, fluid restriction to decrease water retention, D, administration of the drug around 8 to 9 a.m. to mimic diurnal rhythm. The answer is D. Administer the drug daily at 8 to 9 o'clock to mimic normal peak diurnal concentration levels and thereby minimize suppression of the hypothalamic pituitary axis, D. And question 5. Which of the following patient complaints will alert the nurse for possible aldosterone toxicity? A, muscle weakness and abdominal fullness. B, blood pressure of 60/80 millimeters per mercury. C, parched skin and dry mucous membranes. D, all of the above. The answer is A. Signs of toxicity include hypokalemia, weight gain, edema, and hypertension. Muscle weakness and abdominal fullness are signs of hypokalemia. So the answer is A. Let's move on to androgens for male reproductive system drugs. These include the anabolic steroids, oxandrolone, oxymethylone, and nandrolone. These drugs are used illegally, illicitly, by weightlifters. Medically, they're used to promote tissue-building processes and reverse catabolic or tissue-destroying processes, and to increase hemoglobin and red cell mass. So they're used during certain cancers, anemias, angioedemas are used during aplastic anemia to rebuild the bone marrow. They promote weight gain and tissue repair in debilitated patients who've been bedridden for long periods of time. These patients require anabolism in those receiving long-term corticosteroid therapy, and they're used illegally by athletes to promote muscle mass. These drugs are contraindicated in pregnancy and lactation, contraindicated in people with liver dysfunction, contraindicated in people with allergies to the drugs, contraindicated in people with coronary disease, potential increase in cholesterol levels. And also in people with prostate and breast cancer, since these drugs will increase the severity of the cancer. Adverse effects of these drugs in pre-puberty males: virilization, hirsutism, growth of hair, increased skin pigmentation. In post-pubertal males, inhibition of testicular function, gynecomastia, testicular atrophy, priapism, baldness, change in libido. In women, growth of facial hair, hirsutism, hoarseness, deepening of the voice, clitoral enlargement, baldness, irregularities of the menstrual cycle. Drug-drug interactions include oral anticoagulants. There'll be an increased need for anti-diabetic agents in patients who are diabetic, an altered lipid metabolism, and a lack of effectiveness for lipid-lowering agents. Nursing assessment includes looking for those mentioned cautions and contraindications to prevent any untoward complications. You need to perform a thorough physical exam to get a baseline before drug therapy begins. This will also help determine effectiveness of therapy. And also it'll help to evaluate for occurrence of adverse effects. Do an X-ray of the long bones in children to assess the effects of testosterone growth. Look for acute pain related to GI or CNS effects. Look for patients who have disturbed body images related to systemic effects. Administer with food. If GI effects are severe, that can relieve GI distress. Monitor endocrine and liver function. Monitor serum electrolytes before and after therapy. Provide patient teaching. Adverse effects, warning signs, regularly evaluate blood pressure to enhance patient knowledge about drug therapy and to promote compliance with drug therapy. So, to determine if it's working, monitor patient response to therapy. Look for increased hematocrit. Look for increased protein anabolism, increased muscle mass, things like that. 2, monitor adverse effects, androgen-related effects, serum electrolyte disturbances, epiphyseal closure, hepatic dysfunction, things like that. Evaluate patient understanding of drug therapy and monitor patient compliance with drug therapy. Now let's look at hypothalamic drugs. These come in 2 categories: gonadotropin releasing hormone agonists and gonadotropin releasing hormone antagonists. The antagonist ends in Ralex, whereas the agonists tend to end in Ralin. So pulsatile, gonadotropin releasing hormone secretion, stimulates gonadotropins in the anterior pituitary to release gonadotropins, luteinizing hormone and follicle stimulating hormone. But sustained non-pulsatile administration of gonadotropin releasing hormone or gonadotropin releasing hormone analogs inhibits release of follicle stimulating hormone and luteinizing hormone by the pituitary, both in men and women, resulting in hypogonadotropic hypogonadism. So the gonadotropin releasing hormone antagonists are used for fertility protocols. They prevent the surge of luteinizing hormone that'll cause ovulation. So they prevent the ovaries from prematurely releasing immature but maturing ovums. They're also used in advanced prostate cancer in men. And they're also used to decrease the production of sex hormones in people with precocious puberty, endometriosis, advanced prostate and breast cancers. The exception is tesamorelin. This is used to stimulate growth hormone in people with HIV-induced lipodystrophy. HIV-induced lipodystrophy is induced by some drugs that are used to treat HIV. This drug stimulates growth hormone. Growth hormone stimulates a lipolytic effect that decreases abdominal fat in patients with HIV-induced lipodystrophy, tesamorelin. So in children, monitor adverse effects related to overall endocrine function, particularly growth and development and metabolism. You should get a radiographic assay and x-ray of the long bones, monitor blood sugar, monitor electrolytes. In adults, monitor blood sugar, monitor electrolytes. Some of these drugs are administered nasally with a nasal spray form. Review nasal administration of these drugs. Make sure the drugs are properly stored. Make sure the preparations are kept at a cool temperature. Review how to administer them. These are administered usually as IM depots in many cases. And these drugs should not be used in pregnant and lactating women unless the benefits outweigh the risks. In older adults, evaluate hydration, nutrition, and electrolyte balance regularly. And again, review the proper administration and technique. And also note older adults are at high risk for dehydration and ulcerations of the skin as the skin gets thinner as you get older. So these are given as IM depot shots. They have a 4-hour onset of action and about a 1 to 4 month duration. These drugs are contraindicated in people with allergies to the drugs or components in the drugs. If you have vascular disorders, those can alter absorption of the drugs. Absorption of nafarelin nasal spray is altered in people with rhinitis. So you might have to change the dosage of the drug. Renal or hepatic impairment interferes with drug metabolism and excretion. And use either not at all or with great caution in people or when women are pregnant or lactating. The agonists induce at first a flush of sex hormone. So you can get ovarian overstimulation, flushing, increased temperature and appetite, and fluid retention. The antagonists will cause decreased steroid hormone levels, loss of energy, decreased sperm count in men, decreased activity, alterations in secondary sex characteristics, decrease in female sex hormones, amenorrhea, electrolyte changes, insomnia, and increased irritability. So the nursing considerations are drug specific. So check with the drug that's given and review the nursing considerations just because they differ from drug to drug. So let's have another quiz to see how much you've learned. And as it says here, to see how smart you are. So all of these drugs can decrease production of sex hormones, except goserelin, hystrelin, desgarelix, and tesamorelin. The answer is C, desgarelix. Your hypothalamic antagonists, which are A, C, and D, can and do decrease sex hormone production. They are hypothalamic agonists. So you get a resultant drop in production of sex hormones. Desgarelix also, it's an antagonist. It decreases the production of sex hormones, but it's a different drug in a different group than the antagonists. So that's used usually to decrease endogenous sex hormone production while your ovaries are getting ripened for IVF procedures. Which of the following health history data causes you to question the use of hypothalamic agents in a short-term therapy? A, history of hepatic lobe transplantation 3 months ago. B, mother who practices mixed feeding to her newborn baby. She breastfeeds and she feeds with a bottle with formula. C, chest x-ray suggestive of pneumonia. D, fever, probably caused by post-surgical wound infection. The answer is B, mother practices mixed feeding to a newborn baby. These agents are contraindicated in lactating mothers because of potential adverse effects to the neonate. All other options, while they should be signs for caution, are not signs of contraindication. Question 3. Knowing the effects of hypothalamic agents on sex hormones, which of the following medical indications can they be used? A, infertility. B, endometriosis. C, precocious puberty. D, both D and E. The answer is D, both B and C. So the agonists decrease production of sex hormones. Medical indications include endometriosis, precocious puberty. Infertility is best treated by hypothalamic antagonists, not hypothalamic agonists. So the answer is D, both B and C. Question 4. This drug decreases the abdominal fat in HIV-infected patients with lipodystrophy. The answers are A, tesamorelin, B, hystrelin, C, Lupron, otherwise known as Luprolide, and D, nephorelin, which comes in a nasal spray. The answer is A, tesamorelin, which does this by stimulation of the lipolytic effect of growth hormone, A. Last question. Which of the following should be closely monitored in patients receiving hypothalamic agents? A, serum sodium and potassium levels. B, blood sugar levels. C, None of the above, D, A, and B. The answer is D, A, and B. Serum sodium and potassium levels, and B, blood sugar levels. Other aspects that should be monitored include periodic radiographic analysis of long bones, hydration, and nutrition. Very good. So I hope you got a lot out of that. And next time we will talk about diabetes. Very good. Bye.